Donc je donne maintenant la parole à Monsieur Stefano Silvestri, Monsieur Fronda, Franchello, Guglielmino, Campra, Cassine, Chiusa, Fop, Gonella, Campisi de Turin. La fréquence élevée des cellules acineuses et le degré d'infiltration adipeuse au niveau de la tranche de section pancréatique influencent-elles le taux de survenue des fistules pancréatiques après une duodenopancreatectomie céphalique? L'intervenant, Philippe Bachelier.
Okay. Bonjour à tous. Je m'excuse, les diapos sont écrits en français, mais je parle en anglais. J'espère que ce soit bien pour vous. Duodenopancreatectomy has a high rate of postoperative complication. This is especially due to septic complicancies and hemorrhagic events. This also leads to high rate of reintervention and a prolonged hospital stays. This is especially due to pancreatic fistula that increased postoperative mortality, hospital readmission, and costs. Mortality is less than 5% in high volume and experienced center, while morbidity is still high, ranges until 40%. The treatment of pancreatic fistula could be an active treatment, such as with a reintervention. Reintervention that could be a completion pancreatectomy, reanastomosis, salvage pancreatic gastostomy, closure of the pancreatic remnant, and temporary external drainage of the virsung. But could also be a conservative treatment, especially for ESGPS fistula type A and type B, with some advantages for endocrine function, but with an augmented rate of hospitalization and augmented risk of later laparotomy. But as we also said in medicine, the best treatment could be the prevention, or maybe the prevention. This is the reason why now surgeons are facing off with improvement in surgical technique, especially with treatment of pancreatic stump, identification of risk factor, and improvement in preoperative nutritional status. Risk factor could be preoperative risk factor or intraoperative risk factor. We know from the literature that preoperative risk factor are especially radiological risk factor. And this is a paper published in 2012 in Annals of Surgery by Adrien Trachard and the group of Monsieur Beguetti and Monsieur Savanet, in which they found the correlation between visceral fat area and the risk of development of clinically relevant pancreatic fistula type B and type C. They also found that visceral fat area is in strict correlation with lipidic infiltration that better than BMI predict the distribution of fatty in the abdomen. Also, they show in a univariate, but especially in a multivariate analysis in the model, that visceral fat area measured than 84, was the only predictive factor for development of pancreatic fistula. Hereafter, in 2012, a Korean group published a paper with the same results, even if with a major area of visceral fat area. Then, recently in 2013, the group of Boston with Professor Volman and Mark P. Kellery, after a complete revision of the series, at least 500 duodenopancreatectomies, proposed a risk score in which they analyzed the more common risk factor for pancreatic fistula development, such as gland texture, pathology, pancreatic duct diameter, and intraoperative blood loss, and then propose a score ranging from 0 to 10. For example, if we make the hypothesis of a typical case of a soft pancreatic parenchyma, 2 point, for an ampullary carcinoma, 1 point, and with a not dilated virsum diameter, for example, 2 millimeter, we are now at 5 points without excessive blood loss. We note that we have a possibility of a 29% of developing 30%, for development of pancreatic fistula in the postoperative period. As well as intraoperative risk factors are well known and are pancreatic texture, fat infiltration and degree of fibrosis, Wilson diameter, and recently a group proposed acinar cells density measured than 40% as a risk factor. As we know, in 2009, the group of Professor Bachelier with Eduardo Rosso published on Journal of Gastrointestinal Surgery a paper in which they pose in correlation the fatty pancreas, the BMI, the occurrence of pancreatic fistula. They show us how in fat pancreas, with a proportion of measured than 10% of fatty infiltration on the cut surface of the pancreas, that there was a strict correlation with BMI. They also show that in the univariate model, pancreatic fistula development not only correlate with pancreatic texture, neither with Wilson diameter, but also with BMI and especially with pancreatic fat infiltration measured in 10%, as we can note by the ROC curve with the sensitivity and specificity of the ROC curve for the prediction of pancreatic fistula in the postoperative period. Here another paper published in 2010 in Surgery by the group of Beaujon with Sébastien Gaillot that show us how fatty pancreas could predict development of pancreatic fistula, especially in patients younger than 58 years old, in patients with a BMI measured than 25 kilos, and in patients with a soft pancreatic parenchyma. Also in the multivariate model for reaching a risk factor for development of pancreatic fistula, they show us how the only predictive factor and independent predictive factor were BMI, absence of fibrosis, and fatty pancreas. This is the paper which is published in 2012 in Pancreas, in which a Finnish group collected a series of 40 consecutive patients in which they perform a histological analysis. They found two groups, a group with fibrosis, a group without fibrosis, but especially with a high percentage of acinar cells. To note that in each group, the percentage of fat infiltration was exactly the same. They suddenly analyzed the two groups. They posed a cutoff of 40% of prevalence of acinar cell on the transaction line, and they found that there was a strict correlation between postoperative morbidity and the presence or absence of acinar cells. They found that acinar cells measured than 40% strictly correlated with an increased rate of pancreatic fistula and delayed gastric empty. They conclude the study affirming that fibrosis reduced morbidity, while in their study, fat infiltration was not a predictive factor for pancreatic fistula development, and that high frequency of acinar cell on transaction line statistically correlate with morbidity, probably due to the precedent development of acute pancreatitis on the pancreatic stem. Here the aim of our studies was to have an histological evaluation of the pancreatic stem and correlate with the score of fibrosis, score of fat infiltration, and the density of acinar cells, and then to perform a correlation with postoperative morbidity, but especially with the pancreatic fistula development. The setting in which we performed the study was a set of 310 pancreatic duodenectomy in Molinete Hospital until December 2011. There's a series of 46 consecutive patients who have been submitted to duodenopancreatectomy with end-to-end pancreato-jejunal binding anastomosis. All intraoperative evaluation has been done by the same expert surgeon, pancreatic surgeon, and histological evaluation has been done by a single blinded histologic pathology. On the histological evaluation have been expressed a score of fibrosis, a score of fatty infiltration, and the percentage of acinar cells on the transaction line. Then analysis for the more common variables has been done, and the univariate and multivariate model has been performed for reaching the pancreatic fistula risk factor. Here the results of the series: 25 male, 21 female. Most of the patient has been submitted to the classical Cash-Whipple intervention. 30 patients had a hard pancreas. 34 patients had Wilson dilatated, or better, Wilson with a diameter more than 10 millimeters. Most of the patients have been operated for malignant disease. Overall complication rate was 52.1. Pancreatic fistula overall rate was 21.7%. PPH rate, postoperative pancreatic hemorrhage, was 13.5%, while DGA rate was 28%. Reoperation rate was 23%, and the mortality 4%. Hereafter we perform histological analysis and a positive correlation with intraoperative evaluation of pancreatic stump, and we found statistical correlation between R-judged pancreas and fibrotic score, while we failed to show any statistical differences between soft pancreas and fatty infiltration, or neither with the high grade of fatty infiltration. Then we analyzed we pose in correlation BMI and fatty infiltration, finding equal distribution between patients with BMI measured than 25 between the fatty infiltration category, even if we found 6 patients, 44% of total patients, that have a BMI measured than 25 between the high risk category with the high rate of fatty infiltration. Then we failed also to show any differences between the two categories of BMI, major than 25 or less than 25. Also, neither differences has been found, even if a trend there is, between fibrosis and absence or presence of fibrosis and pancreatic fistula. But we found, as in literature, a correlation between high grade of fatty infiltration and pancreatic fistula development. Then we look for correlation between acinar cells and histological characteristics. We found a strict correlation between absence of fibrosis and presence of acinar cells on cuttage. We found the same trend also for the fatty infiltration, and especially for high rate of fatty infiltration, but probably we didn't reach any statistical significance due to the small series of cases. Then we look and we check for correlation between acinar cells density and the more common pancreas-related complicances. We have a strict correlation between acinar cells measured than 20% and development of pancreatic fistula. A trend was also shown for PPH and DGA, and also for intervention, but neither statistical differences have been found for the same reason before. Then univariate model for the development of pancreatic fistula find that male gender, histology, not pancreatic cancer, neither chronic pancreatitis, Wilson diameter less than 3 millimeters, and soft pancreas, and high rate of fatty infiltration, and high rate of acinar cells on transaction line has a significant correlation with pancreatic fistula development. Also to note that in the case of pancreatic fistula development, we reach significant differences in terms of duration of intervention. But in multivariate model, only gender male and histology reach the significant. And so we can affirm that only gender and histology are independent predictive factor in area series for pancreatic fistula development. Brief conclusion. BMI is not in direct correlation with fatty infiltration. Intraoperative evaluation of pancreatic stump could be useful to identify patients at high risk. We have no direct correlation with the high rate of fat infiltration, but could also be useful to predict pancreatic fistula in case of soft pancreas. Then conclusion, reduction and prevention of pancreatic fistula is a topic challenge for a surgeon. We stigmatize the role of the radiological evaluation of the patient before the intervention in order to stratify the risk of pancreatic fistula development. We have found that fat infiltration, high rate of fat infiltration, has a role in development of pancreatic fistula, while gender and histology are independent factors for development of the fistula. Then BMI in our series, it was not useful to identify patient at high risk. BMI, always in our series, it was not a great index of fat infiltration of the pancreas, that sometimes a hard pancreas could be a fatty pancreas. We propose a surgical prognostic role for the frozen section, and we have found that probably the acinar cells density could be an interesting marker, another interesting marker to assess risk pancreas. So at the end, we can affirm that only the perioperative identification of high-risk pancreas could lead to a reduction in the impact of pancreatic fistula, but probably not to a reduction of pancreatic fistula. We stigmatize the role of tailored pancreatic surgery, and we believe that in the next future could be an extensive use of preoperative, especially radiological and clinical risk score to predict the risk, to correlate them with the intraoperative theater, and especially with the frozen section examination, in order to have a tailored anastomosis, especially a pancreatical gastrostomy with, for example, an external Wirsum drainage, and to use in the postoperative period prophylaxis avec octreotide, even if some data against octreotide has been found in literature, and to avoid in those patients fast-track recovery and propose a systematic CT scan on day 5 or day 7 before drainage removal, even if in the topic of drainage a lot of literature is present, and in order to before reintroduce the alimentation. Thank you very much.
Merci. Merci, Monsieur Silvestri. Alors, je passe la parole, bien sûr, à Monsieur Bacholier.
Merci de me passer la parole. Merci de m'avoir invité également. Je voudrais tout d'abord féliciter le docteur Silvestri pour cette présentation qui nous conforte dans ce que l'on sait depuis longtemps par expérience, à savoir que les pancréas gras sont des pancréas fragiles et exposent à un risque plus élevé de fistule pancréatique, qui reste la complication la plus importante dans toute la chirurgie d'exérèse pancréatique. Alors, vous avez cité tous les papiers de la littérature qui donnent un exposé de tout ce qui a été fait récemment, et notamment dans la prédiction par l'imagerie de cette adiposité du pancréas. Est-ce que j'ai plusieurs commentaires et plusieurs questions. La première question, est-ce que dans votre expérience, vous utilisez le scanner tel que ça a été préconisé par l'équipe de Beaujon, ou est-ce que vous avez plutôt l'expérience de l'IRM qui semble beaucoup plus avoir une valeur prédictive beaucoup plus importante pour la prédictibilité de cette adiposité pancréatique, comme ça a été décrit dans le récent papier des Coréens. Vous avez évoqué les éventuelles possibilités de changement de stratégie en fonction de l'adiposité. Est-ce que vous seriez, je dirais, tenté de proposer chez des malades à fort risque une pancréatectomie totale pour ces patients-là? C'est une question un peu provocante que je vous pose, évidemment, en sachant que on peut discuter ensuite des différents anastomos. Deuxième rubrique de questions, c'est lorsque vous découvrez en péropératoire à un pancréas fragile, donc un pancréas gras. Quelle est votre attitude? Quel type d'anastomose allez-vous proposer? Et quelle est votre opinion concernant les drainages, en sachant que les drainages ont montré qu'ils diminuaient un petit peu la gravité de la fistule, mais en aucun cas ne diminuaient le taux de fistule. Voilà.
Alors,
Vous avez compris les questions?
oui, je pense. First question. I think that even if there are two papers in which they use visceral fat area as a predictive factor for development of pancreatic fistula, MRI could be the best radiological tool probably for the assessment of the for the risk. Even if neither scoring has been attached to MRI. No scoring system has been used in the MRI system. In those series of patients, there was a prospective series of 46 patients which we underwent the patient to the same pancreatico-jejunal anastomosis that was the PANC technique. At those periods, we were planning to do a bi-institutional Italian study that has recently been published with the PANC technique. In the preoperative period, we also submitted all the patients to the same CT scan and MRI. We didn't find any differences between possibility of prediction of the risk with the MRI. I know that in literature, many data has been published on the fatty pancreas and MRI, but we didn't find any differences. Probably for our institution now, it's better to assess the risk. We use CT scan to assess the risk, but it's only a morphological risk. You found a bigger pancreas without any lobulation, with or without dilated Wirsung. Okay. In respect of the second question.
Deuxième question, c'était êtes-vous tenté de faire des pancréatectomies totales lorsque le risque vous paraît important?
Could be an option. Even if you have the possibility to reinject the beta cells. Also, we know from the literature that someone proposed a salvage procedure in case of completion pancreatectomy after pancreatic fistula failure to reinject beta cells as a reimplantation of beta cells. And I think that it's probably unethical to propose a complete pancreatectomy for example, for an ampullary carcinoma. But you can discuss with the patient, and if you have the possibility to perform an autologous transplantation of beta cells, probably in a high-risk patient, for example, a patient with BMI, with an increased BMI, or patient with age major, for example, than 65 or 70 years old, probably in next future with great information, you can also propose it.
Si vous me permettez, avant de passer à l'orateur suivant, je voudrais quand même que vous nous précisiez, parce que tout le monde sait ce que c'est que l'infiltration graisseuse du pancréas et le taux de cellules lipidiques, ça c'est assez clair, c'est un pancréas mou qui résiste mal à la suture. Par contre, l'infiltration acineuse, le haut degré d'infiltration acineuse, je voudrais que vous me définissiez ce que ça veut dire. Parce que pour moi, il y a toujours des cellules acineuses au niveau de la tranche du pancréas. C'est la définition même du pancréas. Alors, à partir de quel moment le taux est-il élevé?
Élevé, acinar cells major, covering major than 40% of the area on the transaction line, 40 or less than 40%. They choose that cutoff because in their series of 40 consecutive patients, they found that major or less than 40% of area covered of acinar cell correlate also with the increasing presence or absence of fibrosis. And for them, acinar cells is a sign of, Saint pancreas. a functioning pancreas. While fibrosis, it was a sign of not well-functioning pancreas.
Donc, en fait, c'est indirect. Quand il n'y a que des cellules acineuses, ça veut dire qu'il n'y a pas de fibrose, en fait, par définition. Short.
Juste un petit mot. Enfin, je ne sais pas si je dois parler anglais ou français. Français.
Il est resté 1 an en France.
Ah bon. Non, je suis surpris quand même par ce taux de fistules pancréatiques. Nous faisions beaucoup de chirurgie pancréatique et on avait un taux de fistule très bas. Ça dépend peut-être de la définition. Oui, on a parlé de l'amylase dans le drain, etc. Et je pense que la principale raison, on faisait des anastomoses end-to-side, 3 plans, drain perdu. Et quand le pancréas était très mou, on utilisait le procédé de Mercadier, qui est un procédé qui est très commode. C'est des points en nu qui prennent la tranche du pancréas, qui sont serrés de l'autre côté, en faisant bien attention de mettre un drain justement pour ne pas serrer le virsum. Et on appuie les points du jejunum sur ces points qui sont sur le pancréas. Et c'est un procédé qui est vraiment très solide et qui fait des pancréas très durs. J'ai jamais été élève de Mercadier, mais il l'avait appris dans l'amphithéâtre des hôpitaux. Et je crois que c'est un procédé qui est vraiment très utile. Alors, pour continuer, 1 minute, j'ai eu un élève brésilien qui est venu apprendre la chirurgie hépatique, mais dont le père était le chirurgien pancréatique de Sao Paulo. Et quand il est revenu à Sao Paulo, il a appris la technique de service et les fistules pancréatiques du père ont chuté de manière drastique.
Merci beaucoup, monsieur Lenoir. Donc, vous voulez répondre? Oui, allez-y.
Non.
Non, pas de réponse.
No.
Bon, on vous félicite, on vous remercie.
The third question of Professor Bachelier, was regarding the Wilson gastrinal.
Juste un mot, alors, 1 seconde, parce que la dernière question, c'était quelle anastomose il préconise.
Okay. What kind of anastomosis we perform now? Pancreaticogastrostomy, and in case of small pancreatic duct, we put in the Wilson catheter, external Wilson drainage.
Voilà, merci.
Okay? Only in this case, because this was a consecutive series of patients, and we choose this kind of patient to perform histological analysis because it was a sutureless technique, and so probably we didn't have any traumatism due to the pass of the needle into the pancreatic stump. This was the rationale of the study.
Merci, je suis obligé de passer à la suivante. Merci beaucoup, monsieur.